This is the Menopause Learning Podcast. This is a special CME podcast for physicians, physician assistants, nurse practitioners, and registered pharmacists. I am your host, Dr. Holly Thacker, and I'm the executive producer of National Speaking of Women's Health, and I host a podcast for lay women on Speaking of Women's Health. This podcast series, which provides free CME, is sponsored by a grant by Astellas and Bayer in conjunction with Russ University, Plexus Communications, Advancing Health After Hysterectomy, and Speaking of Women's Health. And you can find more information out about this free CME program and these podcast episodes on menopauselearning.com. Joining us today on this episode in April of 2023 is Dr. Kristi Tough DeSapri. Dr. DeSapri is a board-certified internist, and she specializes in midlife women's health and osteoporosis. And I am very happy to say that Dr. DeSapri is a graduate of our Specialized Women's Health Fellowship at the Cleveland Clinic. And since then, she's worked in both academic medicine and private practice for the last 13 years. And like me, she's the mother of 3 sons. And she's also been the director at Northwestern Women's Bone Program in the Center for Sexual Medicine and Menopause Medicine at Northwest Medicine in Chicago. And very exciting, she's opening a bone and body women's health LCC concierge midlife women's health practice in Winnetka, Illinois. And that's going to be focused on consultation and management of perimenopause, menopause, osteoporosis, and sexual health. And Dr. DeSapri is a national leader in the field of menopause, women's health, and osteoporosis management, and we're going to really focus on osteoporosis today. So she practices with an evidence-based approach, dedicating to women truly as individuals in a very holistic manner. And please be sure to follow Dr. DeSapri on Instagram at boneandbodywh. Thank you so much for joining us, Dr. DeSapri.
Oh, Dr. Thacker, it's such a privilege to be here. Thanks for that introduction. Most of that I owe to you as one of my mentors in teaching me this great field of menopause medicine.
Well, thank you so much, but you are really a true superstar. Your history as a fellow was legendary, and I frequently bring up all the things that you did during your 2-year stint. And you're also North American Menopause certified since 2010. And you also are a very active participant in both the North American Menopause Society and ASBMR, which is the Association of Bone and Mineral Research, ACP, and also BHOF, Bone Health and Osteoporosis Foundation. And importantly, you're a certified clinical densitometrist, so you have your CCD credentials, and that's with the International Society of Clinical Densitometry. And I just recertified for 5 years, both for that and for NAMS. And you gave a fabulous lecture, free CME, on menopauselearning.com earlier on osteoporosis. And so in this podcast, we are going to delve into all these important topics. And I'd first like to start with asking you, who should we consider bone health in, and who should be getting fracture risk assessment, and who should be doing this?
Okay, good question to start off, because I think we have to start from somewhere. Osteoporosis and bone health is such a comprehensive topic, but the first question always becomes, does this apply to me, right? And the answer is, if you're listening to this podcast and you're a clinician, particularly seeing midlife women, which you can define many ways. Many women start to consider symptoms of menopause, perimenopause around the 40s. We know that the average age of menopause is 51 and a half in the United States. However, many women have the menopause transition between 45 and 55. So when you should be thinking about bone health is when you're thinking about all other midlife women's health risk assessments, such as mammograms, such as breast health screenings, such as cardiovascular screenings, and discussing all the lifestyle things that we talk about with our women. So we know that we achieve peak bone mass somewhere between 20 and 30, depending on the skeletal site. So when we think about evaluating for osteoporosis or bone loss, the single largest risk factor I always tell patients are non-modifiable things because you are female and because you will enter menopause and you will lose estrogen, and we're learning more about losing testosterone as well. So when we should think about doing a risk assessment, we think about fractures because that's the endpoint that we're trying to prevent. So similar to when you're seeing your patients for cholesterol screening and you do an LDL and you talk to them about their saturated fat intake and their weight and their lifestyle, it's the same with bone health. We want to be thinking about what was their peak bone mass and what is their risk for the future, and how can we prevent that risk and the risk of a fracture. Fracture is very it's sort of a charged term. A lot of people think of fractures as they had a childhood fracture or they might have had a stress fracture, but the fractures we're trying to prevent with osteoporosis related fractures. In terms of the clinical word, we're moving away from the term fragility fracture because that really signifies that, frail, older individuals, but we know that majority of women who have a fracture, particularly wrist fractures and vertebral fractures, these happen as early as women in their 40s and 50s. And another interesting study from the Women's Health Initiative, when we looked at the bone health study, women who had a low trauma fracture, such as a fall from a standing height, or women who had a traumatic fracture, such as like falling off of a bike or falling from a standing height higher up on a ladder, those women had equally the same risk of having another fracture. So it's very important to think of fractures sort of comprehensively, asking all women over the age of 40, have you had a fracture? Tell me about that fracture. So that we can do that fracture risk assessment and you can decide if a patient needs further evaluation. And the most common way we do that is with a DEXA scan, right? A dual energy X-ray absorptiometry test, which is widely available. It's a low radiation test, one hundredth of a microsievert, so very low radiation that patients are exposed to. It takes about 10 minutes. It's painless. Women do. I do recommend taking off bra and any sort of metal, etc., belly button piercings, etc. When you're doing the DEXA scan. But that's widely available at hospitals. We're seeing that now in the community. Less DEXAs are being done in doctors' offices just because of the reimbursement, but that is something that's widely available. But again, to get back to the initial question, you want to be doing a fracture risk assessment, which looks at when the woman has entered menopause, their risk factors for osteoporosis, which we'll talk about in a second, and then whether or not they should warrant bone density, which is a more formal evaluation of their bone strength.
Now, I imagine that many of the physicians and nurse practitioners and pharmacists and physician assistants listening today probably aren't ISCD certified, or they're probably not reading their own bone densities. But what should they look for when they refer their women patients, or male patients for that matter, for central DEXA scanning?
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
So great question. So because DEXA is done in a variety of different settings by different healthcare professionals, that can be sometimes a radiologist, sometimes an endocrinologist who's reading that. Sometimes we don't know who's reading that. So it's very important that you look at the report, first of all, and that you see what type of DEXA was done. So there's two different types of DEXA technologies that are widely available, both the hologic DEXA and a GE Lunar. So that is mentioned in the report so that you can understand, particularly if you're looking at past DEXAs or you want to know what baseline DEXA this patient is having. You want to look at the indication for the DEXA. So that sometimes is a very common question that I get. You want to make sure that the indication for the DEXA is appropriate. screening for osteoporosis really is not covered by most healthcare insurances until women are 65. So, or if patients have had a fracture. So, oftentimes I use the diagnosis code early menopause, height loss, family history of osteoporosis to get the DEXA, covered. But you want to make sure that you have an appropriate indication there. And then
that's really an important tip. So early menopause, what if the person doesn't have early menopause, or maybe they're adopted, they don't know their family history, they haven't yet lost 1.5 inches of height? Are there other codes that you can put?
Yeah, so family history, like you said, if they don't know their family history, if they've had a fracture, severe vitamin D deficiency, any cause of what we call secondary osteoporosis, which again, we think of primary osteoporosis as bone loss due to just menopause, but there's numerous secondary causes of osteoporosis, meaning osteoporosis or low bone mass caused by steroid use, chronic glucocorticoid use, malabsorption syndromes such as celiac disease or irritable bowel diseases, etc. So you can use any of those secondary causes, and I often refer patients and clinicians even to the Bone Health and Osteoporosis Clinician's Guide that lists a lot of those secondary osteoporosis diagnoses that you could use to sort of strengthen your argument to be doing a bone density scan, particularly for those women between 50 or postmenopause and 64, where the insurance company might sort of push back on the screening DEXA.
And conversely, I've had some women say that if they already have established osteoporosis or osteopenia, the insurance won't code for it, but they'll cover it under prevention. So sometimes I personally just try to list multiple different codes that could be prevention as well as diagnostic. And so far, at least in the last few years, knock on wood, that seems to be a little more helpful, because that is very frustrating to the patient.
Right. And I think that's because our national guidelines really don't have a good grasp on how often we should repeat DEXAs. I mean, that really varies based on the guidelines you're looking at. The Bone Health and Osteoporosis Foundation, the ACE guidelines, which is the endocrine guidelines, the NAMS guidelines are a little bit variable. So really, we do know, though, when women between 50 and 64, again, assuming that menopause occurs at 50 or 51, for those women who menopause occurs earlier, they should absolutely get a screening bone density at baseline to know where they are. Because if they have menopause in their 40s, and we know now the average lifespan of women is living till 80 in their mid 80s, that means half of their life is in menopause. And so what can we do to prevent that second half of their life from being fracture free, from being free of consequences from fracture? And we know that also contributes to the longevity. So again, that is very important. You would do the same thing as you would in childhood for those women. You'd say, okay, use contraceptives, use sunscreen. Those are all preventative things. I think the same thing we should think about a bone density for those early women in early menopause is thinking about the second half of their life and what can we do for prevention.
No, I completely agree. And this grant from Astellas and Bayer to educate clinicians about non-hormonal options for vasomotor symptoms. And so we know that we have hormonal options for vasomotor symptoms, and we know how beneficial estrogen is on the skeleton. But so for somebody who may be having vasomotor symptoms and can't or won't take hormones, certainly we've been more advanced in the bone field for non-hormonal options. And since 1 in 2 women by age 55 have osteoporosis, and obviously men, we're not going to generally be using estrogen to treat their osteoporosis, and there's still men that have osteoporosis. How would you address like your hierarchy of treatment of the bone, and how do you incorporate FRAX into your practice? And tell the audience what FRAX is and how they calculate it, when you use it, when you don't use it.
Okay. Yeah. So, right. So the endpoint of bone mineral density scanning and fracture risk assessment is, trying to predict who will have a fracture and who we can intervene on so we can make a difference, right? And so that's really where FRAX, which is a widely available, free, accessible online tool that was developed with the World Health Organization to look at, how we can better diagnose osteoporosis, and then also who we can find would benefit from treatment. Again, these are population guidelines. So I always say, we are not monkeys, we are clinicians, right? So we can put in any numbers into an algorithm and spit it out, and it can tell you the fracts, and I'll talk about that in a second. But it's very important to also look at your individual patient. So FRAX, again, looks at many different risk factors, such as age, weight, BMI. It asks for family history of hip fracture, particularly parental fracture, mother or father. Don't forget to ask about the father. And that risk is increased, particularly if there is a parental fracture, hip fracture before age 80. It asks for things like glucocorticoid or steroid, prednisone, current use, current smoking, excessive alcohol, and then other secondary osteoporosis, which is a wide net of those conditions I mentioned that you can find in the Bone Health and Osteoporosis Clinician's Guide. Things like, again, malabsorption conditions, severe vitamin D deficiency, medications such as aromatase inhibitors. So lots of things, and many rheumatoid arthritis, diabetes, which we're understanding more, both type 1 and type 2 diabetes that are really affecting the bone density and the bone quality. And then there is a little indicator for where you can enter the femoral neck T-score or BMD if you don't have it into that. And it spits out a little calculation, and it tells you what is the 10-year risk of a hip fracture and a 10-year risk of a major osteoporosis related fracture, which includes the fractures of the humerus, spine, hip, forearm, pelvis, etc. And so there are certain thresholds. If a FRAX score is above 3% for hip fracture and above 20% for a major osteoporosis fracture, then we know that those patients warrant sort of evaluation and potential treatment. The single largest contributor to the FRAX risk assessment is age. So you can play around with the FRAX score, and you can see that many of the women that we might see in their early 40s and 50s with low bone density, particularly like osteopenia, their FRAX risk score is going to be very low, because the reality is the age is one of the strongest determinants, and the reality is the risk of a fall is also lower in your younger years. But we know that after age 65, 1 in 3 women fall annually. And that's something I actually want to very much highlight, because many of us forget to ask, when was the last time you fell? And really what I say in my practice to assess that is, how many times in the past year have you felt unsteady? What about going up and down stairs? Things like that. And we know that there's certain parts of our physical exam, such as balance and the timed up and go, which are very easy. They take less than 2 minutes that we can do in our practice. So the FRAX, again, can be helpful for risk stratification, but it is not the end-all be-all.
Do you report FRAX on all your DEXA reports? I'm just curious.
We'll be back after a quick break.
Have you ever experienced fitness failure? You set a goal to exercise, you're all excited, and then you're not. Hi, I'm Dave. I host the daily 10-minute podcast, Walking is Fitness. Instead of an exercise goal, I talk about making a fitness promise. And every day you keep that promise, you add another link to a growing fitness chain. This is a podcast of action. You'll create a fitness habit, which eventually becomes fitness momentum, and then on to all kinds of good stuff. Check it out. Walking is Fitness, and let's take a daily 10-minute walk together.
So, technically the ISCD says if you have low bone mass or osteopenia, you should report the FRAX. What I find is when the radiologist or a clinician who does not know the patient administers a questionnaire, the FRAX can be often erroneous, because sometimes patients will say, yes, I had a fracture, which is one of the major tenets of FRAX, but they've had a toe fracture, or they've had a fracture, as a child, or, things like that don't really incorporate. And so that makes the FRAX look higher, or they underestimate that they were on a aromatase inhibitor, and secondary osteoporosis is not clicked off. So it's very important that the person who is reading the DEXA looks at the questionnaire and looks at the patient as a full person. And that's what I do. And I know that that's what you do as well, Dr. Thacker. So it's very important that that input is correct if you want to get the correct fracs, and then understand the fracture risk for the patient.
I completely agree. And that's one reason why I'm biased. I think that the best DEXA readers are generally those that see patients and are clinicians. I mean, I love our bone radiologist, and they're certainly excellent in several regards, but so many of those factors factor into it. And I think when looking at outside bone densities, a lot of times people just give me the written report. They don't even give me the pictures. And I think it's important for referring clinicians to know if the site is ISCD certified and if their techs are ISCD certified, because, if you just get garbage numbers, it's hard to make treatment decisions and follow-up decisions.
Absolutely. So the images of the DEXA, and I know if you're a general clinician, and to learn that is difficult, but you do want to be able to look at the images, make sure the scan, if you're looking at one from compared to the other, there are some ways that you can do some comparative analyses. And there's some websites that can help with that. But I see this often, the spine particularly is an area where it's very difficult to interpret. And so the region of interest is different based on how the vertebrae are counted. Or I saw a patient yesterday with a lumbar compression fracture, and that was included in her spine. And obviously I showed the patient, I said, you see your vertebrae from the year before, and then this vertebrae now looks like a pancake. That is a compression fracture, so we have to exclude that vertebrae. And while we're just talking specifics, if you are looking at the spine, you need to have at least 2 contiguous vertebrae that you're looking at to make an analysis. And for a lot of patients with scoliosis or advanced degenerative changes, which we all have because now women are living longer, the spine becomes a site that we cannot interpret so readily and so easily. So it really does require, understanding, looking, of understanding the quality of the bone density you're getting. And you mentioned something, looking at the least significant change. So if we want to be making treatment decisions or looking at how well a medication is working, perhaps maybe you're on one of our osteoporosis medicines, it's very important to try to obtain the bone density on the same machine, particularly the same make of the machine, and if not the same machine itself, so that we can see if that is if those medicines are working or not working. And looking at the percent of change helps determine that. So I know it's a little technical, but it is important, and hopefully you're educating yourself here. Dr. Thacker and I were talking a little bit before about something called the trabecular bone score, which I think you will also start to see that. It's, TBS, it's not the TV station. It's a trabecular bone score, which is a measure of microarchitecture in the spine. So it's a 2D grayscale image, and it sort of erases the artifact of arthritis. So it makes the spine more interpretable for those patients that I just mentioned who might have scoliosis and arthritis. And so it can help us determine the bone quality, or the best estimate that we're thinking. So it's actually very similar to the way that you see a DEXA report, which is either normal, osteopenia, or osteoporosis. The determinants in TBS are degraded, partially degraded, or normal. I know those terms are not really the most patient-friendly and patient-facing terms, but I always tell patients I didn't come up with the names. I sort of I say, what we're thinking about is we're looking at the inside of the bone, and it helps give us a fuller picture of what the bone strength actually is, because we know that 60% of our bone strength can be estimated by bone density. So when people tell me, why did I get a bone density, or what does this actually mean, or, oh, I had a fracture, but it's not that big of a deal. And then you see that their bone density is low, meaning they're, 60% of that, it predicts 60% of their bone strength, and their bone quality, their trabecular bone score is low. That again can help us educate our patients. Actually, there is an underlying bone issue. You do have osteoporosis, you have clinical osteoporosis, you have bone thinning. And how that portends for the future is that we know from numerous observational studies that once you had one fracture, your risk of having another fracture is exponentially higher, possibly about 20%. 20 to 30% of women who have sustained a fracture will have another fracture within the next 5 years. And that risk can continue for even longer because we're all aging as well. And then we start to have to think about falls. So it's so important for the women we see in their 40s and 50s who have a fracture to really identify this is osteoporosis and actually use the terms. Because what I find a lot of general practitioners do is they say, oh, your bone density shows osteopenia in one site and osteoporosis in another. And the patient comes to me saying, well, it's just a little bit of osteoporosis, or my doctor said this mixed diagnosis, and they're coming completely confused. So it's very important to say, yes, you have osteoporosis. Yes, you have clinical osteoporosis. You might be healthy in all your other ways, but we need to figure out how we can, we can treat this condition and move forward
Yes.
beyond it.
Because fractures are so devastating, and you can't get that height back. Even if you end up having kyphoplasty, you're not still going to get that same height, and that's a whole other discussion. So then tips are, if you're lucky enough to have someone in your area that's ISCD certified and has trabecular bone scoring, you'd want to do that. I know I'm the only one at our Cleveland Clinic Health System that has the trabecular bone scoring, based on the expense and just my philanthropic fundraising. But we're going to report our outcomes for the last year, and we did change the diagnosis in 16% of patients with the trabecular bone scoring, 11% worse diagnosis and 5% actually better. And I think a lot of thin women who just have light bones, who never break bones and don't have any other risk, it's very reassuring when you see that normal bone architecture. And conversely, you can see women that have normal bone density but degraded bone architecture. And so that's going to make you think about other secondary causes and other things that have to be evaluated. Can you give me your list of tests that you tend to order in women that you want to rule out secondary causes of osteoporosis?
Sure, absolutely. So when you see a woman with osteoporosis, you can always say, yeah, sure, it might be due to menopause or their thin body mass, or maybe they were a smoker, or they have some genetic family history. We know Asian women have a lower bone density. But really, for most women, particularly if they have a low Z score, which again, a Z score compares as a number on the DEXA report that looks at comparing women of a similar age, race, and sex match. However, it doesn't need to be always less than -2 to warrant a secondary workup. There's much research that shows that only a third of the time, we'll find a secondary cause of osteoporosis. But for many women, the Z score of -2 does not always portend a secondary cause. So you really want to look at the T in the Z score. But if you see a woman who's younger or even middle age with osteoporosis, it warrants a secondary workup, and it's very simple to do, actually. So many of the tests have already probably been done when you look at the labs already done. So you want to do a comprehensive metabolic profile, including a phosphorus, because I see a lot of cases of HPP, which is hypophosphatasia, and we can fix that. And we don't want to put patients on anti-resorptive therapy if they have that condition, which I've seen many times, and they do worse. You want to be checking a magnesium. You want to check a thyroid, a 25 hydroxy vitamin D, a celiac panel, and that can be done many different ways. Some people do or have had that done on an endoscopy and had a biopsy, but most of that is done in a serology. However, we're finding more and more serology negative celiac condition. So if you do feel a patient might warrant symptoms of that, you do want to have them do an endoscopy as well. I do have patients do a 24-hour urine calcium, which is
So do I.
which is actually, sometimes we get a little bit of pushback. I'm sure you do too.
A
But
lot. Half
yeah,
the people don't even complete
yeah,
it, and my order expires in
yeah.
two months.
So a 24-hour urine calcium, what is that looking for? So I actually tell patients it's sort of like the Goldilocks phenomenon of calcium. So sometimes, too much calcium isn't good, too little calcium isn't good. So just enough is where we're looking for. So a 24-hour in calcium is exactly that, collecting your urine in a 1 to 2 liter jug for 24 full hours, off any calcium supplements, particularly if we're looking for idiopathic hypercalciuria, which actually has been reported in about 7% of osteoporosis cases, which means that people are losing a defect in the distal convoluted tubular and are not reabsorbing calcium in that collecting system. And so that can be easily treated with a thiazide diuretic. And so we should find that and treat for that so that they're not continuing to lose calcium. For some women who are very deficient in calcium, like malabsorptive symptoms, I do have them do a 24-hour urine calcium, taking calcium supplements so that I can make sure that they're getting enough. And then am I missing any? And then a parathyroid hormone, PTH, particularly if you are looking for parathyroid conditions, which we're finding many more normal calcemic hyperparathyroidism now that we're checking for this. And the guidelines have changed for how we evaluate and detect that. So that's an easy, again, blood test to do. And if you need to also do an ionized calcium, that's important as well. And then I also check a serum protein. Last one is I check a serum protein electrophoresis, and occasionally, and that goes along with an immunofixation. And occasionally, I'll also do that in the urine because we're also finding so many cases of MGUS. That if the free light chains are elevated, et cetera, I will send to hematology. And that's a condition that we're just following along with. And we know that because of the low proteins that are, the high proteins secreted from the bone marrow, that can infiltrate the bone and cause low bone density. Oftentimes, these patients just need monitoring, once-a-year serologies. Very rarely does this deteriorate into multiple myeloma, but we do see that at least a couple cases a year as well.
You know, in my experience, I find more than 7% that have the renal tubular defect with hypercalciuria. And so anyone with kidney stones, even if their bone density is normal, I usually will screen. But most cases I find low doses, 12.5 milligrams of daily hydrochlorothiazide is enough to stop the calcium leak, and we make them repeat it. Mm-hmm. But unfortunately, I see a lot of clinicians take women off of it, saying you don't have hypertension. Mm-hmm. And even if they tend to have low normal blood pressures, that low dose isn't going to further drop their blood pressure. But I do have some women that's not enough, and apparently hygrotin actually has some osteoblastic effects. So that 25 milligram dose might be more effective in some of the tougher cases.
Like, right, chlorothalidone you're talking about?
Chlorothalidone. Yeah. Usually they tend to drop potassium with that.
Well, yeah, the other point just about that too is, yes, I have a lot of patients who have resistant and use that. You do have to check the potassium. Sometimes I'll use like spironolactone instead, even though that does not affect the calcium, but that can sometimes offset some of the losses. For patients, and I have them taking it in the morning because we don't want to be causing, our urgent, urinary frequency and things like that at night.
So moving on to treatments, obviously estrogen and hormone therapy is approved for prevention and management. And your last lecture that people can watch on menopauselearning.com covers that. So we'll take that class out for time's sake, since we've got about maybe 15 more minutes. I want you to talk about the different classes of medicines, why they're not created equally, how you kind of stratify postmenopausal women for these bone therapies.
Sure. So I know we don't have a lot of time to talk about estrogen, but I always feel like it gets overlooked. So I'm just going to say a couple seconds because the way that I say it, sorry, Holly. So the way I always think about this is because estrogen is forgotten, right? So for the woman who is early menopause to 60, there's a lot of classes of medicines, anti-resorptives, which we'll talk about, and bone anabolics. But for those patients who are low risk, who maybe want to prevent bone loss, maybe they have a osteoporosis with a T-score of, minus 2.5, and you've done a secondary workup. Many of them probably have another reason to use hormone therapy as well: mood symptoms, sleep symptoms, dyspareunia. Hormone therapy at standard doses can really help. And if they see an endocrinologist or a rheumatologist or an orthopedic surgeon or a bone health clinic that's not with, comfortable with hormone therapy, they will never be offered that. So
I know
I would say educate yourself to give those patients hormone therapy if you think that is the right option for them. Okay. So we'll move on. And then, in terms of the other, large classes of medicines that we use, really the people who tell us how we can use these medicines are the best guidelines, I think, are the NAMS guidelines, the ACE guidelines. And it really looks at, again, risk stratifying the patient. So women with very high fracture risks, that can be defined as an elevated FRAX score, even higher than what we talked about as threshold. So a FRAX score of over 30% of a major osteoporosis fracture. Women who've had one or multiple osteoporosis-related fractures, multiple spinal fractures, recent fractures, very low T-scores, again, -3 to -3.5 or lower, and age. As I said, age increases our risk for fracture, so over age 70. Any constellation of those characteristics, so multiple fractures, age, and very low T-score, warrant patients to get the therapy that's the most effective. And we know from many comparative studies now that the osteoanabolic, so this is not steroids, it's bone building medications. And now we thankfully have 3. So we have 2 that are in the class of something called the parathyroid or PTH agonists that work on the parathyroid receptor to intermittently stimulate osteoblastic formation and to a lesser extent also increase anti-resorptive activity, but the net effect for those medicines is going to be bone building. So those medications are called abaloparatide or Tymlos, and the other medication is teriparatide or Forteo. So that whole class of medicines has been FDA approved since 2002. So really, over 20 years of use of those medicines. Those medicines are sort of cousins, and they're very equally efficacious in reducing the risk of vertebral fractures. They are the medicines that reduce the risk of vertebral fracture by over 80%. And so I use those preferentially in patients who have a high risk for vertebral fractures, very low T-scores, have had vertebral fractures in the past, but they also have efficacy to reduce the risk of a hip fracture. So that's that sort of class of anabolic. And then we have another class of osteoanabolic medicines, which is called romosozumab or Evenity. So that works a little bit differently. It actually has also a dual effect, but it stimulates the osteoblast by inhibiting something we call sclerostin. So it actually inhibits the inhibitor of bone formation. So it's sort of a double negative. And to a lesser extent, it inhibits bone resorption. So this is medicine that's a 1-year medicine that is given by a healthcare provider every single month, 2 small syringes, again, by a healthcare provider covered by Medicare Part B and D, and is highly effective both reducing vertebral fractures and hip fractures. So again, the net is that to understanding risk stratifying your patient and then, thinking about an anabolic agent for those patients. And then we sort of skip over to the anti-resorptive therapies, which for many years was the mainstay of our treatment because it's all we had. So actually hormone therapy is a weak anti-resorptive therapy. We have another one called raloxifene or Avista, which is now generic and has been out since the 1990s, which is, again, it's sort of on par with hormone therapy in terms of its anti-resorptive effect. So used for women who might be a lower risk for fracture. Perhaps they also have a increased breast density, a family history of breast cancer, because we know that it reduces the estrogen receptor positive breast cancer after 5 years of use. But we know that from the core trial that this can be used for up to 8 years if it still continue to be effective. And that I use for a lot of my women between their 50s and 70s who are at low to moderate risk, particularly if they have a low spine bone density, because we know that all of our medicines are going to preferentially affect the trabecular bone, which is more concentrated in the spine. And so we're going to see bigger effects and better fracture reductions in the spine than we are in the hip, which is a more concentrated cortical bone. And then we move to the large class of bisphosphonates, which are oral bisphosphonates, alendronate, risedronate, abandronate, which are given in various doses. And I always like to remind people that alendronate comes in a liquid form. It comes now in an effervescent tablet form for some patients who can't take oral pills, and these cannot be crushed. Again, these are medicines that affect the bone remodeling, so they inhibit bone resorption by working on the active areas of bone resorption or bone remodeling. So it fills in the bone that's missing. And we know that these are used for anywhere at interval between 3 and 5 years now. That is the current recommendation, because we know after 5 years, there's a plateau effect, meaning the bone mineral density does not really change much, and the fracture risk reduction does not change much either. And if you have a patient that's higher risk, they probably need a different class of medicines. We need to outweigh the risk of a long-term therapy of bisphosphonates, which can sometimes shut down the remodeling system and then contribute to microfractures or stress fractures, which are, again, very rare, but we want to be thinking about these things for long-term use, particularly in patients perhaps that are Asian ethnicity, patients who are on steroids, who have glucocorticoids, who are on PPIs. We really want to be thinking about these very rare risks as we go beyond 5 years. But the reality is, for women who are on oral bisphosphonates for less than 5 years, the risk is 1 in 100,000 to develop an atypical femoral fracture. There's been likened that you're more likely to get hit by lightning than you are to have one of these rare fractures. If you want to ask about that, you ask about hip or thigh or groin pain that's unexplained, and you can document that in your clinical note. Yes, no. If you think yes, then you should get x-rays of the pelvis and of the femur to evaluate for any atypical fracture. There is also an IV bisphosphonate form, which is zoledronic acid or reclass, which is given once yearly or every 18 months, actually, for women who are of moderate risk, who are in their 70s, and it can be actually given also every other year for prevention, and again, obviously bypasses the GI tract. This is given over 15 minutes, but can be spread out in your infusion centers to be given over 30 minutes or even 45 minutes for better tolerability. Pre-infusion counseling is very important for these patients so that they tolerate it better, because a third of women will have acute phase reaction, such as joint aches and pains, low-grade fever, which during the time of COVID, these symptoms overlap. So I had a lot of patients who were like, I don't know if it's COVID or I had this reaction, but generally those reactions less than 72 hours. If a patient has symptoms that last longer, you want to be rechecking their electrolytes. You can be giving them NSAIDs. In the rare case, I'll give patients a short course of steroids to help them through the aches and pains, low-grade fever. Hydration is very important. And then
I found that tends to be worse with the first infusion and worse if people have low vitamin Ds. So we will not infuse anyone with a 25 hydroxy vitamin D under 32, and I prefer to push people to 50 or 60.
Exactly. So women, right, the average vitamin D, generally, most of the medical societies are saying at least between 30 and 60 nanograms per milliliter. But like you said, I think there's evidence between 40 and 60 or even a little bit higher to, prevent the hypocalcemic response. And absolutely, that's so important because, if women have undiagnosed celiac disease, again, one of the reasons why we should do a secondary workup. I've had countless patients say, oh, I did horribly on this medicine, and then we find out that they had celiac disease or their vitamin D was low, and of course they're going to have a side effect because they have no substrate to pull from. I actually had a very interesting patient yesterday with uveitis from reclass, but that is, again, less than 0.1%, but I'd seen it a couple times, I think once.
And more in the people with MUGUS.
Right, exactly.
And renal impairment.
Right. So these are medicines that are well tolerated. You do need to have a lot of education, though, to tell patients, because what's going to happen is they're going to go to the internet and read about them and then say, oh, look at these rare side effects. So go to the Bone Health and Clinicians Osteoporosis Foundation website, educate yourself, give the patient education from there so they can delve into that. That's very, very important. And then the last of the anti-resorptives is denosumab, or it's also called Prolia. This has been FDA approved since 2010. I remember when I was a fellow, then it was coming out, and now we have more than 12 years of use, clinically, a lot of data on this. This is a very unique medication because it affects something called the rank ligand, which is one of the some receptor-activated nuclear kappa, which is part of our cytokine systems. So it binds very aggressively and prevents the osteoclast from functioning and from surviving. And so it's a very potent anti-remodeling agent. This is given by subcutaneous injection every 6 months by, again, a healthcare provider. During the COVID pandemic, some patients were giving it to themselves, but now we're really moving away from that. This is very safe, very effective. Again, you also need to make sure normal vitamin Ds. This is not renally excreted as bisphosphonates are, which I forgot to mention. So this is more useful in your patients with CKD. However, patients with like CKD 4 or 5, you still want to be very astute about checking their electrolytes and counseling them. This is a medicine that is, unlike bisphosphonates, does not have a drug holiday. So that term has really been coined since I think that, around that really only constitutes what happens with bisphosphonates. There is no drug holiday with Prolia. So if you are starting Prolia because a patient is at a high risk for fracture, because this is a more potent option, and we know that the compliance compared to oral bisphosphonates in a couple studies now is better because, again, it's being injected right into your arm, and we can follow this clinically. But if you are going to stop that or discontinue for whatever reason, insurance, you're moving, you had a side effect, it does need to be followed with a transition. And generally, we're finding that oral or IV bisphosphonates is probably the best next step. It has been used for up to 10 years continuously. So for my patients who are high risk in their 70s, 80s, 90s, I even have a couple 100-year-olds who are on this medicine. This is a continuous use. So you really want to be talking and educating up front for the patient who's going to start Prolia. This is an area that is very active in investigation because perhaps a different time frame of use of Prolia for a couple years might be effective, and then transitioning onto something else because we know this potently reduces the risk of fracture. So in my practice, I do different things. I have some patients who are on for continuous. I have some patients who I use it for a couple years and then transition. And we know for the breast patients who are on aromatase inhibitors, this is also approved for postmenopausal osteoporosis, but also to prevent bone loss from aromatase inhibitors. It's also used to prevent bone loss and treat osteoporosis from glucocorticoids. So there's many indications for denosumab, but you do need to make sure that you're educating the patient up front. This compliance is very important. And if you transition for any reason, that needs to be done delicately.
So on the anabolics, do you have any rule that if someone completes 1 year of monthly Romo Evenity or 2 years of either Forteo or the biosimilar Boncity or abaloparatide, which is Tymlos, after 2 years that they have to get it either Prolia afterwards for solidification or IV reclassed, or do you also use oral bisphosphonates or other therapies?
Yeah, so I think the term that you're referring to is sequential therapy. So just like we set up the discussion at the beginning that osteoporosis is a chronic condition, and I always tell people, 70% of women have a hip fracture. That's the same amount of men who have a heart attack. So we're trying to prevent fractures over the long time. So just like 12 months of therapy isn't going to like fix it all and with a nice neat bow. So we need to continue on with therapy. So if it's an anabolic therapy, the recommendation is to follow with one of our classes of anti-resorptive therapy, whether that be a patient who's at very high risk for fracture. Maybe they're elderly, they've had a fracture, they can't take an oral bisphosphonate. We follow that with, yes, IV zoledronic acid or IV reclast. That can be done sometimes for 1 to 2 years. The studies have been done, particularly something called the Active Extend trial has been done with abaloparatide, looking at 18 months of Tymlos or abaloparatide followed by 2 years of oral alendronate. It maintained the bone density. The fracture risk remained very low, both in vertebral and hip fractures. Following that with IV reclast has also been studied. And then we look conversely at Evenity or romosozumab, 12 years, followed by both Prolia for 2 to 3 years, or followed Evenity followed by oral alendronate, which was the ARCH study. Both showed that bone mineral density can be maintained and fracture risk reduction was also maintained. What happens after that time is, again, going to be a reassessment with your DEXA, reassessment with the patient's fracture risk and whether they warrant a drug holiday for a short period of time or whether they need another treatment. And so this is where sort of like the art and science of bone health medicine sort of comes in, right? We're trying to prevent fractures, but we're also looking at potential side effects, fall risk, calcium, vitamin D, nutritional status of these patients. And so it's an ongoing discussion. It's not just a one and done.
Just one common mistake I've seen of patients that are physicians and nurses themselves who get anabolics and see their bone density improve, and then they just go off into the sunset and then reappear several years later with fractures. And you've just wasted all that time and money in a way. I mean, maybe you push things out a little bit, but it just seems like a waste. And I don't think that's common knowledge amongst, all physician groups, that if you're going to use the anabolic, you want to solidify that and not just go off into the sunset.
Right. And I'm of the camp, exactly. Thanks, Holly. I'm of the camp that, you use the anabolics early, and this is what's changing in the paradigm. Right.
If you can, financially.
Well, but there is actually in the paradigm, now there is evidence, the Vero trial that looked at Forteo versus Residronate, the Frame trial, the Arch trial that looked at alendronate versus Evenity. We know that these medicines, these anabolic medicines, have a better efficacy at fracture reduction and are just as equally tolerable or better. And so we should start with those for high fractures patients, and particularly who are women under age 65. I know a lot of our insurance companies unfortunately dictates how we do things. However, when I see patients with a low bone density under age 65, or they've had fractures, I really push towards using the anabolics, and particularly the parathyroid agonists, because they are going to be covered by insurance. They can get a $0 to $4 copay with commercial insurance. And so
it takes a lot of work, though. And one thing I do when I write letters is I say that the patient is in grave danger of a fracture.
Right. I mean, I think the education is there, but again, we're having patients give themselves injections for, weight loss medicines and for migraines.
Yeah. And that's going to be our next CME podcast.
Right. So good. Okay. Good segue. Patients can do this, and they can be motivated to do this or taught to do this. And I do this in my office. You can have train a nurse to do this.
Yes.
There's videos online. So my patients say, I just looked it online. I can do it. It's sometimes getting over the needle phobia, but the needles are 31 gauge needle, and it's 2 years, and you're boosting your bone. I see patients and they say, my gosh, my bone density improved so much. I can't believe it. I said, well, why do you think we did this? So it's very important to try and find, if you can, the ideal medicine for the patient, talking to them, but looking at their fracture risk, and then obviously working with our insurance companies. But we do have, I wish we had more, but we do have things covered by Medicare, daily injections, oral, IV, lots of options. So I always give patients, a couple options with my sort of, Cadillac recommendation, and then, okay, let's work together. If you don't want to do this one, what's another one that we can choose with understanding the risk benefit profile and also the longevity of the treatment.
Well, this has been so helpful. I really appreciate this, Dr. DeSapri. Can you tell our listeners where they can contact you, your website again?
Sure. Yeah. So I'm opening my practice, Bone and Body Women's Health, in Winnetka, Illinois, but I will also be seeing patients virtually. So my website is https://boneandbodywh.com.
Oh, that's excellent. That's excellent. And for all of our listeners, please be sure to go on menopauselearning.com and answer your questions and claim your free CME credit. And if you're on the Convey Medical app, there's also other free podcasts on women's health and managing menopause and menopause learning. So thank you so much. We really appreciate Dr. DeSapri's expertise and being in the Sunflower House and our Speaking of Women's Health CME podcast. Wishing everybody a great day. Be strong, be healthy, be in charge. Take your calcium and vitamin D and get your exercise, and see a bone expert or see your healthcare provider. Thank you.
Thank you.